few students who are anonymized, who are going to take the Viva today. And I will give them, each student will be given a few cases, and then the next student and the next student. I will ask the student who is going to tackle a film to unmute him, and I'm going to use pseudonames for them. And they will tackle the case, and so only that student and myself you can hear. Rest, please keep yourself muted. Another thing is that I realize that this is all new, and there might be many feedback points from your side, so you use your chat box for that, and we can, of course, improve things and things like that. IT issues, I'm sure there are IT issues going on, which we will be able to resolve. So, candidate 2, are you with us? If you are, please unmute yourself and acknowledge that you are with us.
Yeah, hi, I'm here.
Okay, so case for you, please. Over to you. So please remember, audience, that this is FRCR Viva, and consider that this case has been put on the screen by the examiner. Over to you, candidate 2.
Okay, so this is the frontal radiograph of the cervical spine and upper facts. There is a well-defined calcific density adjacent to the right 7th vertebra. It's well-defined and doesn't appear to be separate from the vertebra. So my first possible differential is it could be an omovertebra. I can't see anything in the lung fields. The remaining bone appears to be normal. So omovertebra will probably be my differential, most likely differential for this.
So what is an omovertebral body or omovertebral bone?
So it's usually a connection between the vertebra and the scapula.
And when do you see that?
I think there's some associated conditions you can get it with. Klippel-Feil syndrome is one of them. Pycnodystosis.
Do you see any stigmata of anything on this film?
No.
What do you think is this?
I can't see.
Where I am pointing out, what do you think is this?
Oh, that's the right scapula, is it? So yeah, so it's connecting the right scapula to the 7th vertebra, which will be in keeping with it, and the scapula appears to be elevated, so it says Sprengel deformity.
Okay, that's fine, well done. So this is a type of film which in FRCR language we call it edge of the film case. Edge of the film case. What is edge of the film? There might be something at the edge of the film which will give you the hint. If you look carefully, there is something here, and if you compare it with this space, then you understand that there is something sitting there, and then there is a sort of a bone here. So what happens is that this is known as Spengler's shoulder. Spengler's shoulder, if you go back to your embryology, this, by the way, is another case. If you go back to your embryology, what happens is that the shoulder girdle actually is developed in the neck, and from there it descends downwards. So sometimes it doesn't descend down, and the scapula is arrested. It's a high riding type of scapula. This scapula is a smaller scapula than usual. It has got a equilateral type of a configuration. Many of the times, this scapula, particularly the medial border, is connected to the spine with a bone. is known as homovertebral bone. And not in this case, by the way, it's not there. Many a times there is no bone and there might be something which is a fibrous band which you won't see it. Tender shoulder is also at times associated with other conditions. Now, I'll come back to the conditions, but if you look carefully on this one, this is another case, and where you can see that there are some rib abnormalities. So rib abnormalities can be there, and there can be other abnormalities in the cervical spine. They have shown Sprengel shoulder, which is bilateral on a chest X-ray. And please remember that it's a difficult case because human eye picks up asymmetry. Bilateral shoulder at times becomes a bit difficult to pick up. This is another example where you can see similar to the if you can mute yourself, please, all of you. Now, if in this particular case, you can see the same bone here. So this is that homovertebral bone, which is also in here. Now, this one, on the other hand, is what we call Klippel-Feil syndrome. In Klippel-Feil, there is loss of segmentation of the cervical vertebrae, and this thing can also be associated with Sprengel shoulder. So this is the chest X-ray of the same case, this case. And you can see that there is a high riding scapula, and with that, you can see all of this, loss of segmentation or fusion, and you can see rib abnormalities. Similarly, other cervical spine abnormalities like spina bifida, etc., that is also associated at times. Case 2 for you, candidate 2. Still, this is your YY is continuing.
So this is a frontal and lateral radiograph of the left wrist. Apparent abnormality in the position of the carpal bones and the distal radius. It appears to be V-shaped in origin, and there's also some widening of the radial arms. This can be in keeping with Madelung deformity. I would have a look at the carpal, any signs of shortened carpals to see if there's any signs of Turner syndrome. It doesn't look traumatic, which would be a less likely differential. So in summary, it looks like Madelung deformity of the wrist.
Okay, well done. So in Madelung deformity, basically what happens is that the basic problem is that the medial portion of the epiphysis of the radius, here where I'm pointing out, this is not formed. And because of that, the carpus, they actually herniate backwards, and you can see a bit of subluxation at the distal radio-ulnar joint. There is subluxation there. And if you see on the lateral view, there is posterior subluxation of the radius. So I warn you of the ulna. And I warn you that an examiner can actually start with this film, lateral. And this is what we call the bayonet deformity. This is a bayonet as on the rifle. So this can also happen that you might be given the lateral film as the first film to diagnose it. There is a bit of differential diagnosis. You did mention other things in your description. You were ruling out things, and you did well where you ruled out also Turner syndrome. Now, Turner syndrome, if you see this case, candidate 2, this is Turner syndrome. Can you describe and tell me why is it Turner syndrome?
So there's shortening of the fourth and fifth metacarpal, which is pathognomonic of or can be seen in Turner syndrome. There also appears to be subluxation of the patella, which I believe can also be seen with the added Madelung deformity. So altogether, this would be in keeping with Turner's.
Right. So this is the word which we use as a unifying diagnosis. So if you see the differential diagnosis here, there are multiple things which can, which can be with Madelung deformity. And isolated Madelung deformity is the most common, right? Having said that, here what is happening is that you have got short metacarpals, usually fourth, but with that, third and fifth can also be short in Turner syndrome. And in Turner syndrome, I've just given you, for the sake of making it a unifying diagnosis, at times the medial epiphysis of the tibia, that is also flattened like this. But this finding, don't expect it in the exam. This is enough for the exam, because fourth metacarpal, short fourth metacarpal per se is a exam differential diagnosis, and it has come in the exam. And Turner is a specific thing there because of the Madelung deformity, but it can also happen because of these two, pseudo and pseudo hypoparathyroidism. These are important for the exam. We will do it when we do the endocrine. So a unifying diagnosis will be Turner's. Still with candidate 2. Over to you. 3 months. Normal, abnormal. What is the abnormality? We are worried.
So this is a frontal radiograph in an immature skeleton, and the hips bilaterally appear to be dislocated. Dysplasia of the hips. They don't appear to be in the normal positions. I can't see any associated fracture or any other bony abnormalities.
Right. So you have done well. You have picked up the diagnosis, which is developmental dysplasia of the hip and bilateral dislocation or subluxation, whatever. But the point is that in your description started with the diagnosis. And the diagnosis was correct. You started off with the diagnosis of bilateral, subluxation or dislocation, whatever. You have to, first of all, describe it and then reach a conclusion about the diagnosis. So can you please tell me that how did you reach this conclusion? Can you describe it first of all, and then reach the same conclusion which was correct?
So if you draw Perkins lines and Hellinger's line, the femoral head should be on the medial inner aspect. But here, if you just sort of imagine the lines, it appears to be in the outer quadrant, but bilaterally.
Excellent. Well done. So if you see here, by the way, DDH, we are not expecting DDH to be shown to you on a plain film, because they will show you ultrasound, and they have shown many times ultrasound, but still they can show plain film for the simple reason that even in first world countries like UK, still there are patients who are neglected babies. They might present at 8 months age with this thing, not an ultrasound, but a plain film finding. Of course, in a third world country, it happens more often. Now, if you see here, The femoral capital epiphysis, which is barely seen here, the femoral capital epiphysis is a very important epiphysis for you. And there are many films in which this will tell you a sort of a age of the patient. And it appears, there is a range between about 4 months till about 7 months, somewhere in that category. So here you can see this one, but barely, you can have a debate if this is visible or not. But actually, you can infer where it will be because this is the neck. So you can infer that it is sitting there. Now, if you draw two lines, one of the line, which is known as Hill-Jenriner's line, it passes through the triradiate cartilage. Second line is perpendicular to this, which is known as Perkins' line, and it passes through the anterior inferior iliac spine. So the point is that this femoral capital epiphysis should be sitting in the inner lower quadrant here. And in our case, it is outer and outer. So this is developmental dysplasia of the head. Okay, so candidate 2, thank you very much. Well done. So we are going to candidate 16 now. If 16 is with us, can you acknowledge?
Yep, hi.
Okay, so this is your case, please.
This is a frontal and lateral photographs of an initial skeleton. There is gross abnormality seen of the distal tibia and fibula, which appears to have fractures through with evidence of callus formation. There's also bowing of the distal tibia and fibula. These findings are most likely in keeping with osteogenesis imperfecta. I would want to look at other x-rays of the patient to look for other fractures to help me confirm the diagnosis. I'd also want to ask the clinical team for more information. For example, do they have a hearing aid or any deafness? Other things I would want to consider would be neurofibromatosis, or I should also consider NAI and malformed healed fractures.
Right. So first of all, let's go to your description, and you asked for other films, which is fine, but there was nothing on other films. This is not osteogenesis imperfecta, right? Mm-hmm. Second thing in your differential diagnosis was neurofibromatosis, and that is the correct diagnosis. You tell me why.
I'm trying to look for soft tissue nodules seen throughout the soft tissues. On closer inspection, I can see there are a few soft tissue.
No, not here. So don't worry. There is nothing in the soft tissues in this case. This particular entity, how do you describe it? What happens in neurofibromatosis? So that's why I've confirmed your diagnosis is correct, but you tell me why.
They get tibial bowing and pseudoarthrosis.
Yeah, very good. Pseudoarthrosis is a good answer. Why does pseudoarthrosis, why it is sort of in this particular case, it is quite pathognomic of pseudoarthrosis. There can be so many causes of pseudoarthrosis, but once you know whole of the history and everything else, then and look at the appearance. Okay, fine. Your third differential was NAI. Mm-hmm. Can you reconsider that? Why did you say NAI?
I just thought it was safe to say, given that there were fractures and I should always have it at the back of my mind, even though it is unlikely that this
So
is.
NAI, where does NAI happen within the bones, I mean to say?
You get buccal fractures.
So metaphyseal, right?
Mm-hmm.
Okay, so let me first of all go through it, and then you will understand what happens. This case is an extremely important case because if you know it, you will immediately grab it. If you don't know it, it becomes a sort of a, absolute pain. Basically, in NF1, neurofibromatosis 1, this case can also come to you as a long case. In long cases, this might be a film, and with that, some other stigmata of NF1, maybe in a MR of the brain or something. And the unifying diagnosis will be NF1. So what happens is that these patients have got dysplasia of the bone, most commonly tibia, but other bones can be involved, long bones. Basically, clinically speaking, they might have a board type of appearance of a limb. It can be lower limb, it can be upper limb. Then what happens is, if you see this picture, that there might be thinning. There is a concept of bone resorption, and then when the bone is resorbed, we don't know why does it happen. There can be pseudo fractures or there can be true fractures. And what happens, if you see here, the case which you were seeing, there is a cupping, a pencil and cup type of deformity, and look at the edges become very sharp. So this is quite a pathognomic finding of pseudoarthrosis. We call it congenital pseudoarthrosis. And look at this picture here. And again, there is bone resorption. That is why it gives you this appearance. And look at this cupping. So this is NF1, pseudoarthrosis. NAI, please remember, NAI will have metaphyseal fractures. Now, so as I've told you, that NF1 is a very, very important case, or very, very important, or very favorite of examiners, NF1, and multi-system type of cases they do come in the exam. So this is one of the plain film which can come with let's say an MR of the spine or MR of the brain, etc., with other stigmata. Okay, so this is your second case. This patient is a 9-year-old female, and the patient has presented with right foot pain. This is the left foot, this is the right foot. And this is the epifilm. There was nothing on the epifilm. So let me tell you that epifilm was not helpful in this case. So just concentrate on these laterals and try to see if there is a difference between left and right. Over to you, please.
So looking more closely at the left and right lateral foot x-rays, the most obvious abnormality I can see is there is a bony protrusion of the anterior talus, which is seen on the right foot but not seen on the left. I think this is a congenital variation, but I think it can be associated with pain.
So very good observations, well done. So let me elaborate for the audience that if you see here, this is the talus and this is the navicular, and this is the talus and this is the navicular, and this has been picked up here. Something is there, we call it talar beaking. Now your inference, candidate 16, is that there is some sort of congenital abnormality. What kind of congenital abnormality would be? So your thinking is very, absolutely spot on. But my question is very specific. What kind of congenital abnormality?
I thought it was the beaking, but is that seen with coalition?
Okay, very good. Well done. So, what kind of view can help you further?
I would have wanted to see the AP in closer.
AP is normal, as I've shown you.
Normal. Okay.
AP was not helpful.
Perhaps. How about an oblique view?
Sorry, which view?
Would an oblique view help me?
Oblique view. Okay, well done. So here you are. And I will also show you a sort of a close-up of this. This is a close-up.
Close-up.
So this is left, this is right. So your this is your left, this is right?
Mm-hmm.
So here, let me correct myself. This is right here, and this is left. This small view. Anything?
I'd want to look more closely to look at the talus and the carcanial to see if they are separate or if there's evidence of coalition there.
Now, do you see any difference between here versus here? This is the calcaneum. This is the navicular. So there is a joint between here. And do you see a difference, this versus this? Agreed or not?
Agree.
And so you can see that this joint space, it gives you a slightly irregular type of margin. And if you see, look at the margin here, and this is very well defined. This is irregular, maybe a bit of sclerosis is there. What comes to your mind?
Calcano-navicular coalition, but fibrous, not bony.
Excellent, well done. Okay, so
hello?
We go back to the, hello, can you hear me, please?
Yeah, my internet just keeps on jumping a bit. What did you say? If we go back to the
I'm now summing up the case, so I'm not asking you a question. Your diagnosis is correct, okay? Now, collation-wise, this is again quite a favorite case for the examination. So remember a few basics. The most common collations are subtalar collation and calcaneo-navicular collation, both about equal percentage-wise. And there can be other type of collations, but they are not for the exam because they are more rare. Whenever collation occur, there are some indirect signs which you will pick up. So what happens is that the talo-navicular joint, it becomes very rigid and it does not move normally. And because of that, there are abnormal stresses here and a bit of sort of a pseudo-osteophyte formation type of a picture where you get this talar beaking. So look for talar beaking, and in the exam, they are going to show you a lateral for that. So the eye sees what the mind knows. As soon as you pick this up and look at the age, they will be, young children, adolescent children, or young adults. Then your mind goes into, it can be either calcaneo-navicular or subtalar. Point to remember is that calcaneo-navicular is best seen on oblique view. AP view is useless. It is best seen on oblique view. And the subtalar one can be seen on an axial view. You know the DP view of the calcaneum. So I'll show you a case. So these views are very important for you to remember. I repeat, calcaneonavicular oblique, subtalar axial view. And this is what they are expecting for you to pick up. Another thing in the exam is they might show you only one side. And a leading question by the examiner will be, what will you do next? And the answer is, I will do the X-ray of the other foot also. Why? Up to 20 to 25, some people think 30-35% cases are bilateral. This is a leading exam question. What will you do next? I will do the other foot also. And if they want, they might show you the other foot. Now, with that background, look at the concept. The concept is that collation can be fibrous, it can be cartilaginous, and it can be bony. So bony means there is a bony bar. When there is cartilaginous or fibrous collation, then you will see some changes around in the bone. Sclerosis, some the joint space might be reduced and things like that. But you will not find a bony bar. MR is considered very sensitive there. But in many cases, you might actually CT, some people think might be a savior. Having said that, usually in an FRCR exam, they go for plain films. So let me show you a few more examples. So this was calcaneonavicular collation. Well done. So still with you, candidate 16, this is again your case.
So again, there is left anterior talar beaking.
Excellent. So because you are doing collation, so you asked for AP film, you asked for oblique film, and there was nothing. What else will you ask then?
We asked for the axial to look for subtalar.
This is the axial. Let me give you a hint. This is the normal side. This is the abnormal.
Okay. Sorry, which one is abnormal?
Can you see my mouse?
The red cursor.
Laser. So this is the abnormal.
Okay.
I think your annotation function maybe is working. If you can switch that off.
I can't see it.
You cannot see it.
No, I don't know.
Fine. That is a good answer. So let me go back to the basics. Look at this. This is your calcaneum. Calcaneum, now one of the landmark is this aspect, which is known as the sustentaculum tali, which projects medially. Now, calcaneum has got three facets, and this is the anterior articular facet, this is the middle, and this is the posterior. The posterior is the largest. Middle is overlying the sustentaculum tali, and this is the anterior. This is where the action is. So, middle, you have to remember for the exam. And though it can happen in the posterior also. Now, your normal anatomy is that if you see, this is the sustentaculum tali. This joint here is the middle joint, right? And look at this middle joint, and you will agree that there is irregularity. Look at the joint space. The joint space is reduced, irregular. Look at the marginal sclerosis. So indirectly, there is a collation, but this collation is not bony. So this is subtalar collation. Okay, because of film factor, I will just describe the film and ask you a leading question. You can on this. There is a color beacon, and what else? There is a sign there, and this time the collation can be diagnosed just from this X-ray.
So there's a bony bar between the talus and the navicular bone, and loss of joint space.
Bony bar is not very convincing. It's overlapping. No. A bit of stretch of imagination. There is a sign there. I want to hear the name. Do you see this thing?
Oh, the sustenaculae tali?
No, this sign is known as C sign. So what happens is, this will be, if you go back just to refresh your anatomy, go to lateral, and this is how it projects, right? This projects. This thing becomes very, very dense and prominent, right? So this is a normal type of an appearance, but then it becomes abnormally dense and very well defined. So, and with this is quite pathognomic of what we call, a frank collation. And this time, what is happening, that there is a what we call a bony bar at the same joint, the middle subtalar joint, and this is how it projects on a lateral. This is a CT scan. And MR. This is another case, by the way, and you can see this bony bar on an MR also. Okay, this is just to show you the same thing on CT scan. So right, left, right, left, right, left, right, left, right, left, right, left. The abnormality is on the left side. You tell me which joints are involved. Remember, anterior, middle, and posterior.
The middle articular surface is...
Okay, so if you see here, this is the, and here you can appreciate that there is no bony bar, but the joint space is reduced. There is sclerosis. What about the posterior?
The posterior is the largest. The posterior looks preserved.
If you see here,
reduced, okay.
Yeah, reduced, right? This is the level of the fibula. So the point is that posterior as well as this one. So this was a coronal view of the anterior facet, the middle facet, and the posterior facet. Some of the other you are getting feet and feet. So what is your diagnosis? Spot diagnosis. 5-second diagnosis.
Are they missing the... They've got rocker bottom feet? So like the talus looks very what's that word? The talus has an abnormal configuration.
Yeah, excellent. So rocker bottom foot is basically a vertical talus, right? The configuration which you are talking about is a vertical talus. And interestingly, as I've told you that these are the type of cases which have come in the exam, and only about 2 exams ago somebody got it. I never used to teach rocker bottom foot to my students because I thought that this is too specialized or whatever. But it was asked in the exam. And basically in rocker bottom foot, what happens is vertical talus means that technically there will be a talonavicular dislocation. Even if navicular is not ossified, you cannot see it, you can infer that it will be out of socket. There are a few lines which are given here. The mid-talar line should pass through the base of first metatarsal, the mid-calcaneal line to base of fourth metatarsals, and they are not seen. In an exam case, I don't think so. You should go for lines. It is obvious that this is more vertical. It should have been like this, right? So rocker bottom foot can also be seen in acquired conditions. You just name this. What is this? Candidate 16, question for you. This is 7-year-old, and this is rocker bottom foot as an acquired condition. What is it?
There's destruction. There's bone destruction of the anterior talus. As well as the metatarsal bones as well.
So your diagnosis?
My diagnosis, Charcot's foot.
Excellent. So this is Charcot joint, classical. We will cover it in our 4th chapter. But here what happens is that this is a diabetic foot where there is bony destruction. Look at the density, which is increased. And if the inference is that there has to be because the navicular is destroyed, there is a dislocation there. And you can see that rocker bottom effect. Okay, now is a time for a 5-minute break. The next candidate is number 13. Can number 13 unmute?
Hello, can you hear me?
Yes. So this is number 13, correct?
Yes.
Okay, so I will now go to you.
Okay, this is a frontal radiograph of the skull of a 1-year-old male showing increased bone density of both.
Don't worry about bone density. That is right. Please continue.
Right. I think there is thickening of the skull bones, or is it projectional?
Thickening of what?
Thickening of the skull table, or is it projectional?
No, forget about it.
All right. I'm looking at the clavicles.
Excellent.
They seem to be not well formed.
Very good.
So my differential diagnosis could be Cleidocranial dysostosis. I'm searching for any Wormian bones, but I cannot see this clearly. There is a differential diagnosis for hypoplastic or dysplastic clavicles. I really don't remember, I only remember the Cleidocranial dysostosis.
Okay, well done.
Right,
okay, so if you see here, I can ask you, okay, before I take over, let me ask you another question. What is other than cleidocranial dysplasia, anything else in the congenital world which you will consider in the differential?
Yeah, the chest wall seems abnormal too.
That's fine. That is an observation, which is a correct observation. But I was saying anything else in the differential diagnosis from congenital world.
I don't have anything on mind.
Right. Okay. So if you see here, in this particular case, look at the clavicle, and part of the clavicle is not well formed, and part of it is hypoplastic. With that, even the scapula, particularly look at the glenoid, and they are small. If you look at the skull, these are vermian bones. You see this fontanelle is open. For a 1 year old, this is too much. It should have been, close to just, should I say, this is 1 year. And then if you see here, these are vermian bones. Vermian bones are bones which are within the suture. Key in this case is to comment on the mandible. And that is a key exam point. And I will tell you why. Now, if you see the film of the rest of the abdomen and pelvis, first thing which comes to the mind is that look at the pubic symphysis, and there is widening of pubic symphysis. Even look at the posterior elements of the vertebra. So this is the vertebral body, and this is not joint. And look at the rib, and these are short ribs. But these are all, subtle findings. The main findings is this one. So now comes the art of differential diagnosis. The first diagnosis is, in your Chapman, this is 1.28, page 27 in the new edition. Erosion or absence of the outer end of clavicle. And these are the most common causes, which we will see examples of later on. But in the less common, you can see this Cleidocranial dysplasia, and second thing is pycnodysostosis. So please remember, these two are asked in the exam because both of them are congenital. Hyperpara, rheumatoid, all of these things are very, very important. But in this world, these two are critical: cleidocranial dysplasia and pycnodysostosis. So, how do you differentiate between the two? There are things and there are some discriminators which I am going to teach you. Another differential diagnosis in which both of them go together is widening of symphysis pubis. And even here you can see cleidocranial dysplasia, pycnodysostosis. Basic pathology in cleidocranial dysplasia is that there is poor ossification of cartilage. The membranous ossification of bone is deficient. So that is the difference. Now, this is another example where it's a 14-year-old, but if you get this film, you start describing things, but then you understand that there is no clavicle. Clavicles are missing. Look at the glenoid, and the glenoid is sort of small. And this is rest of the findings of cleidocranial dysplasia. Now, look at the vermian bones. Vermian bones are bones within the sutures. For example, this one is a vermian bone. The key finding, look at the pubic symphysis, poorly ossified. The key finding is this thing, mandible. The mandible is normal. And why is it important? It is a discriminator, one of the discriminator to discriminate it from pycnodysostosis. If you see the maxilla, it is small, but mandible is normal. And there is an angle of mandible. So this is the main difference. And there is another difference which I am going to highlight. So now, candidate 13, if you can tackle this film.
Yes. Okay. So these are frontal and lateral.
So let me tell you that this is pycnodysostoses, right? You
Yes.
tell why is this pycnodysostoses?
First of all, there is no angle of the mandible,
Okay.
and I can see worm and bone in the lambdoid suture.
Okay. Anything else?
No, not to my eyes.
Okay. I of course, because of projection, it might not be visible to you, but look at the bone density. There is a bit of sclerosis. But
Yes.
look here at the base of the skull, and you will appreciate there is a bit of sclerosis. Look at the orbital margins, and they are all sclerosed. Bone density in the exam is always slightly, difficult to pick up at times because of projection, but the examiners are going to help you. So if you say that there is increased bone density and they tell you don't worry, then fine. Otherwise, they might help you. So the key thing here is in that there is increased bone density. And otherwise, quite a few common things happen in pycnodysostoses, and that's why you can confuse it with cleidocranial dysplasia. I will come back to this film, but can you describe it for me? What are the findings?
Okay, so there is increased or diffuse bone sclerosis. There is also negative ulnar variance. There is short force metacarpals.
What's happening to the distal tufts here?
Yeah, acrosteosis.
Acro-osteolysis. Right. So now in pycnodysostosis also, clavicles can be absent, or part of the clavicles can be absent. There can be Wormian bones and things like that. Acro-osteolysis can be there. In Cleidocranial, usually there is no acro-osteolysis. Key discriminator between the two is mandible. Mandible will be small and obtuse in cleidocranial dysplasia. And another finding is that bone sclerosis. So in pycnodysostosis, there will be bone density will be increased. This concept is extremely important for you to remember. If you go back to the metabolism of bone, we know that there is a concept of what we call the concept of bone. There are osteoblasts and there are osteoclasts. So bone remodeling. Osteoblasts, they produce bone, and the osteoclasts, they then remodel it. When osteoclasts have got some issues, maybe in number or their, you can get bony dysplasias in which there is sclerosis of bone. And this is a spectrum of conditions, and the spectrum can be from extremely, whole of the bone skeleton will be high density versus slightly less versus more lesser, and lesser. And this is exam case, this is exam case, this is for differential diagnosis, otherwise no. This is exam case and this is exam case. All of them are exam cases in which there is a spectrum of sclerotic bony dysplasia. So in pycnodysostosis, this is what can happen. If you see the medullary cavities, you will see that they are encroached and they are not very well seen. So this was pycnodysostosis. In your book, there are causes of generalized increased bone density in a child. Extremely important differential diagnosis. But in dysplasia, you can see the names which I have told you. I have not told you this one, but otherwise osteopetrosis, pycnodysostoses, Engelmann's disease, melorheostosis, these ones you have to remember. And please remember for ST1s, gradually as you go through the whole curriculum, you have to then learn what will happen here, and you have to then learn what will happen in the poisoning, etc. And so finally, 2 years down the road, you might be able to discuss on a particular case what is the cause of increased bone density. And similarly, in adults, generalized increased bone density, it becomes slightly different. But please remember, a patient who has got pycnodysostoses as a child will become an adult, right? With pycnodysostoses. So these conditions which happen in onset in pediatric group ultimately might be seen in an adult age group also. Another differential diagnosis in your book is about distal phalangeal destruction, and out of the less common cause, pycnodysostoses is given there. Okay. Please, can you tackle this case?
No, yes. Okay, this is a frontal radiograph of the skull. There is abnormal shape of the skull vault. Maybe it's taking trichocephaly or towering of the skull. The clavicles are normal in shape. I cannot really appreciate the rami of the mandible very well, but maybe it's just an over-penetrated film.
Yeah, don't worry about mandible.
Yeah.
So, if you see here, this is portion of the temporal bone, how it is bulging, and something is projecting here. I will show you a lateral. And now, concentrate on this area, and can you reach a diagnosis?
Okay, so there is, the petrous bone is supposed to be dense. I think this density is maybe
the cervical spine.
Yes. Not really sure what's happening.
Right. And this is osteogenesis imperfecta. In Scottish literature, Demoshunter skull, this is that cap. Actually, also in literature, you will see this word floppy hat sign for this. Actually, if you see here what is happening, let me explain to you. First of all, look here. This is C1, this is the dens of C2, and this is the foramen magnum, this is the clivus. Now, if you draw a line from this point, which is the posterior inner border of foramen magnum, you draw a line towards the heart palate here. And this tip of dens should not be for more than 4.5 millimeter superior to that. And when it is more than that, we call it basilar invagination. Now, basilar invagination can have various kinds of causes, congenital as well as acquired. If you just remember it, that basically in the bone is not normal. It is, just remember it like that, that it is soft bone. And invagination means that the cervical spine goes into the foramen magnum. So this is what happens in osteogenesis imperfecta. This will also happen in these conditions like Paget's disease, hyperparathyroidism, osteomalacia, rickets. In rheumatoid arthritis, it happens because of subluxation at the atlantoaxial, occipital joint, which I will show you when we reach rheumatoid arthritis. But having said that, this is a very, very good case, and please remember, if you see it once, you will know it, otherwise you are going to miss it. You have to stretch your imagination here, because the dents is not very well seen, but where is the dents? And, this was the line of the heart palate, and you can imagine it has gone in. So this bulges out the temporal bone and the occipital bone, giving you this Thermoschneider skull or a floppy head sign, whatever you want to call it. Yes, please.
Okay, so there is a generalized increase in the bone density, giving a picture frame appearance involving all the radiographed bones. The differential diagnosis is Osteopetrosis, which is marble bone disease, maybe myelofibrosis. If the patient is a child, I'm more inclined to the marble bone disease.
Why is it a child and why is it not a child, and why will it not matter? Osteopetrosis can happen to a child who becomes an adult, isn't it?
Yes, it's like a mild form, yes.
So the point is that is there some specific sign here where you can say that this is osteopetrosis?
This picture frame of the vertebra.
Okay. Anything else?
I can see some soft tissue calcifications over the left upper quadrant.
Okay. No, I'm not interested there. Anything else? Right. So let me take over. Basically, this is osteopetrosis, and why is it osteopetrosis? Please remember that osteopetrosis is what we call the sclerotic bony dysplasia, which is of most significant magnitude. And osteopetrosis has got a cyclic type of pattern. So cyclic pattern means that there are cycles where normal bone deposition is there, and then there will be more sclerotic bone deposition, and it goes into cycles. People don't know why it happens like this, but this particular sign gives you some leeway to diagnose it. The cyclic pattern will give you normal bone density versus sclerotic bone density at particular parts of anatomy. You will get this bone within bone appearance in the vertebrae like this. You can get lucencies at the metaphyses, which are perpendicular to the long axis of metaphyses. And in the diaphyses, not in this particular case, it's not visible. You can get lucencies which are along the longitudinal axis. But at the iliac wings, you will get this arcuate type of, lucencies or bone within bone appearance. Bone and within bone appearance. This is considered quite specific for osteopetrosis. Now, again, a repetition of generalized increased bone densities in children and adults. This is the bone within bone appearance differential diagnosis, 14.14. This is another case of osteopetrosis. Can you just describe to me how will you describe this thing, Timur?
It's flask shape.
Excellent. So this flask shape means that there is an issue with modeling of the femur, remodeling. And there is a bit of a differential diagnosis for this. Erlen-Meyer flask deformity. And you have to remember these because they can also come in the exam. Osteopetrosis is one of them. Thalassemia, Gaucher's and lead poisoning are the others. Okay, now this is a very important case for the exam. It has come quite a few times.
Yes, I think it's melorheostosis.
Can you describe it for me?
Yes, there is not diffuse, like there is thickening of the cortex of the femur and tibia on the right side, I assume. And it's just candle, like molten candle, dropping wax, candle wax on the bony cortex. This is how it's classically described. Can you hear me?
I can hear you. You've done well. Okay, so let me describe melorheostosis and what happens there. Basically, please remember that it is one of the sclerotic bony dysplasia. So the osteoclasts are not working normal, and there will be deposition of bone both on the periosteal as well as end-osteal surface of the bone. So this is the periosteal surface. This is the end-osteal. ST1, this vocabulary, you have to develop this end-osteal means inner side, right? This is the medullary cavity. And in a long bone, it goes along the shaft to give you this molten wax type of and classical appearance. If you look at this case, look at the tibia, and again you can see this particular type of pattern. So this is melorheostosis, and I will show you a few further cases here as an examples. And so this is in hand, and this is in clavicle, this one here. This is in first metatarsal here. So if you know it, it becomes very simple. Otherwise, you will be always struggling about it. Now, this particular case I have kept for differential diagnosis. Can you please tell me what, there is a bit of sclerosis, but anatomically speaking, can you describe it for us? Where is it?
Okay, so it's right here.
Excellent. So if you look carefully, this is the epiphysis, this is maybe the metaphysis. It is normal, but there is sclerosis, and just like the previous case, but it's more bilateral symmetrical. Same thing happening in tibia, same thing happening in fibula. And if you go to the other side, this is the right and this is the left, and you can see the same thing. This is for the differential of sclerotic bony dysplasia, and this is what we call Engelmann's disease, diaphyseal dysplasia. If you remember diaphyseal dysplasia, automatically it tells you what it is. This is your last case.
Yeah, this is spot on osteopoikilosis, multiple.
Osteopoikilosis is a simple case, but of course it becomes simple once you know it. Basically, osteopoikilosis, pathologically speaking, is just like multiple bone beds, and these are round joints usually. So if you see here, they can be lanceolate or oval or rounded. They are usually around big joints on both sides. Just like this case, this is quite classical, and this is known as osteoporosis, not to be confused with anything more sinister. Okay, thank you very much.
Thank you.
Oh, next is number 15. If you are hearing me, if you can unmute yourself.
Yep, hearing loud and clear.
Okay, so yes, please, over to you.
This is a frontal pelvic radiograph of a child. The striking abnormality is located at the intertrochanteric region of the right proximal femur, where there is a lesion within the bone centered in the medullary cavity that has a thick sclerotic border, but is generally lucent with a ground glass matrix. I think reversing this lesion, which I would be specifically concerned about if the patient's presented with pain. In terms of the likely etiology, I think it has appearances consistent with fibrous dysplasia, in which case I would like to assess whether there were clinical reasons to suspect polyostotic disease and image other areas of the skeleton accordingly.
Okay, excellent, well done. So if you see here, in this case, what is happening is that there is a lesion, and this lesion has got particular configuration. There, by the way, is a fracture also. Now, if you see, part of the lesion has got ground glass type of an appearance. On one of the pathognomic findings, can everybody mute themselves, please? If you see, there is a pathognomic finding is this sclerotic rim around the lesion, and if you look at CT, this is very good for learning what is happening inside. What is happening inside is that you have got some matrix which is slightly what we call ground glass type of matrix, and then there are some cystic spaces also. Surrounding that is a thick rim of ossification or calcification. This thick rim is known as the rind of orange appearance, and it is considered absolutely pathognomic of fibrous dysplasia. Nothing else will give you this kind of thick rim. So let's go back to the basics and consider the various kinds of, the concepts of fibrous dysplasia and what kind of films can come in the exam. It is one of the most favorite pathologies to be shown in the exam. And even it is shown in head and neck, for example, or skull and CNS. And if you know the pathology, you can make your radiology. What I've seen is that inexperienced people, they think that fibrous dysplasia means ground glass. No, fibrous dysplasia can be ground glass, but can be other kinds of appearances. So we have to go back to the pathology. First of all, look at the word ground glass. And this is from Wikipedia. Ground glass is a glass whose surface has been ground to produce a flat but rough matte finish. So this is the appearance. It is a sort of an opaque type of a glass. This is known as ground glass appearance, classically seen here. But let's go back to the pathology. Actually, what happens, it is a dysplasia. So there is a concept of monoostotic versus polyostotic. Monoostotic means only one bone is involved. In polyostotic, there are patients in which more than 80-90% of the skeleton might be involved, but it is never symmetrical. Polyostotic fibrous dysplasia occurs much earlier age, maybe in the first decade, and fibrous dysplasia presents otherwise in second or third decade. Presentation is young. In polyostotic fibrous dysplasia, one thing which is very important to remember is that the facial skeleton, particularly the maxilla, mandible, these can be quite commonly involved. Base of skull can also be involved. Now, pathologically speaking, so if you know the pathology, you can make the radiology. Basically, what is happening in fibrous dysplasia is that there is fibrous tissue as well as cysts within the medullary. Let's consider the medullary cavity. Within the medullary cavity. Now, then what happens is these cysts, some of them have got blood and some of them might not have blood. Irrelevant, because what happens is that this fibrous tissue starts ossifying to a various degree. And at a particular, if it ossifies to a particular degree, it might give you a fibrous type of, a ground glass type of an appearance. So take home point is that fibrous dysplasia can be lytic, can be ground glass, and can also be sclerotic. Many a times it has got a mixed picture. Don't get confused. And within a long bone, the location is metadiaphysis, just like this example. So polyostotic fibrous dysplasias are always confused. If you don't know it, in the exam, you will confuse it. Look at this case. This is a beautiful case where what is happening, look at this metatarsal, metacarpal, and you can see that the medullary cavity is obliterated. You don't see the medullary cavity, it is obliterated, and then there is this ground glass. Some lucencies are there, and then there is a lytic lesion here in the distal. This should not confuse you. If you don't know that fibrous dysplasia can have lytic appearance also, you will always confuse this. So that is why I say, know the pathology and make your radiology. So I'll show you many examples of fibrous dysplasia just to show you various kinds of presentations of the same condition. Another case of fibrous dysplasia, and the pathognomic finding is the rind of orange appearance. If you see it, just call it. There is nothing else which will give you this kind of appearance. Okay, candidate 15, can you describe it for us? We know it is fibrous dysplasia, but I want to see your description. So I'm going to give you your description.
So this is a focused radiograph frontal of the right hip and proximal femur of a child. There is a bony dysplasia with abnormal contour to the proximal femur where there is coxa valga, and the entire epiphysis, metaphysis, and most of the visualized diaphysis have a thin cortex with a ground glass matrix. There's evidence of probably previous fracture, most notably at approximately the junction of the proximal third and distal 2/3 of the diaphysis. And I think the visualized pelvis also looks abnormal. Therefore, I suspect that the skeletal dysplasia that is demonstrated here is polyostotic. Other than that, I think there's also some periosteal reaction evident at the lateral border of the femur.
Right. What is this